Tissue Integrity Part 4, Introduction to Nursing Concepts, Martha Olson. As we look at removing the bacteria from that wound, we know that it's very specific. We use a 35 milliliter syringe with a 19 gauge angiocath or needle. The rationale for that is the 19 gauge delivers the right amount of PSI or pressure to that wound bed so that it does not damage the wound bed, but it in fact loosens and removes the bacteria from that. About 1 inch above the wound is how you hold that, and there's a nice picture in your book that shows that we will be talking about. The Asepto syringe should not be used because it doesn't give enough pressure. So in looking at skill 48.5 on page 1224 in the Potter and Perry, it recommends giving an analgesic 30 minutes before. Ask if they need to use the restroom so that you're not in the middle of this procedure when they say, I really need to go to the bathroom. And then make sure you position the patient so that they are comfortable, but yet you will be removing the fluid from that wound in a way that you have control. Most of the time we will put a blue chucks under the area where that drainage is going to be so we don't have to get the bed wet and change the linen. Make sure you gather your supplies, and sometimes it's helpful to have somebody around to be able to help if you forget something or need another piece of equipment in doing this so that you don't have to unglove and go out and get that. Wear goggles if you think it's going to splash at all. They highly recommend that when you have a deeper wound that you're irrigating, gown and gloves would be recommended. So as you can see, we are cleansing the wound here. They are positioned so that it is rolling off toward that white rag off to the left, and then your 19 gauge needle is irrigating that wound in a way that is not putting too much pressure on that. As we look at page 1199, this is cleansing that wound. They're going from the inside out. You would never want to irrigate from the wound edges in because the wound edges are probably more contaminated to that. The pressure then is to removes the bacteria, and it's clean to dirty or usually inner to outer on that wound. Cleansing with a whirlpool or shower is recommended. The shower for about 10 or 15 minutes. Remember, the shower points the water on the wound and then takes it off. You would never want to put somebody in a bath where they are sitting in their dirty water that's been in their peri area and then having that cleanse over that. So that's why the shower is often recommended. If you have a whirlpool in your facility, that may be used, but the person at home then would be recommended to take a shower. For the whirlpool, make sure it's getting cleaned well between patients so that you aren't contaminating or getting germs from another person into the other people that are taking the whirlpool shower. The wound is very hypersensitive to hot temperatures, so you need to moderate that very carefully as to not do more tissue damage. Things we do not want to use are listed here. If in doubt, ask. Normal saline is the one thing we know that is very helpful to that wound. It's the same as what is in the body, and so it does not do any damage to the tissue. Hydrogen peroxide that probably all of you have at home in that brown bottle in your medicine cupboard is not recommended. I remember as a kid, you'd pour the hydrogen peroxide on a wound and you'd stand and watch it bubble and clean out, and that was like a way cool thing to do, but we know that hydrogen peroxide damages that healthy tissue underneath and is not recommended. So our normal saline comes in a bottle that's called 0.9 NS or normal saline on that. It's very stable. If you get a new bottle off the shelf, you don't have to worry about it being sterile or clean, but if this is a bottle that you are using over and over, when you initiate it, you want to date and time it so that it's used according to your policy in your facility for the length of time that it can be used. And if you are using a bottle that's previously been opened, you will want to put your hand on the front of the bottle to protect the label. Pour some off to clean the lip of that bottle, pour it off into the garbage, and then pour into your sterile field to be using that. For some of our local wound infections, they will use a bacitracin. It's a little pad that you rip open and it's got the ointment in there. Many times we will send those home with people. If they come into the ER and they have a wound, we send a bunch of those home with directions of how to put that on the wound that they have. The other one you see listed is Silvadene. That is primarily used for burns, and it's very helpful. It is a product that you have to assess for allergies and also just not overuse because it can get into trouble that way. A wound will not move through the phases of wound healing if the wound is infected. So in thinking about that, these topical antibiotics such as bacitracin can be very helpful to keep that wound from being infected. On page 1183 in Potter and Perry, it goes through the different stages of epidermal repair. We know that about 24 to 72 hours after the injury, we have the proliferation that is peaking at that time. In a moist environment, those new epithelial cells migrate across that moist surface and will heal that wound a lot quicker. A moist wound heals in 4 days. If it's dry, it takes almost twice as long for it to heal. The different stages are listed here. Am I really worried that you can identify what stage of wound healing it's in? Not really. My concern for the test and for you as a good nurse would be looking at the cares, the prevention, and keeping that wound from getting an infection. In the differentiation stage, we see the new epidermis is pink, dry, and very fragile. With a full thickness wound, we see loss of tissue. Usually your chronic wounds like a pressure ulcer would be considered a full thickness wound because it's all the way down through that tissue area. Our inflammatory phase, proliferative phase, and remodeling phase again are talked about in the Potter and Perry. When we look at the inflammatory phase, we know that we want to control the bleeding, so we have a lot of the cells that come and help remove the bleeding from that area. The hemostasis platelets come and help with the coagulation process, and also vasoconstriction to help control that bleeding. Our clots form then kind of a matrix, a fibrin matrix or a framework, so that the body can then start to make that area over the top of that wound that it has. It's red and swollen during this time. The swelling is as a result of all of these platelets and cells coming to the rescue to help with that. Our proliferative phase is next. That's where we see new capillaries, new oxygen coming to that area to promote another layer of that collagen being laid down. This is usually day 3 to 24 in our wound management. It's filling with our granulation tissue, and it's now giving us some strength. The wound will contract or kind of shrivel and shrink as a result during that phase. And then our remodeling phase is the last phase talked about in Potter and Perry on 1183, where our collagen scar reorganizes and gains strength for several months. The scar has fewer pigmented cells. It's lighter than color than normal skin, but this phase lasts up to 1 year. And so when we look at a wound, a secondary intention wound, we know that that skin is never as strong as the original skin, the tensile strength of that. Potter and Perry recommends that we continue with the healthy nutrition and positive protein in the diet to help heal this. And as our scar that's never more than 80% of the non-wounded skin is going to be at high risk for breaking down again in the person if they have issues in the future. So as we work with our elderly population and the decubiti that they have, if that heals, it's never as strong, and that area is at high risk in the future to break down again. This is PowerPoint number 4. As we've talked about the cleansing of the wound, remember the 35 milliliter syringe with that 19 gauge abacath is the recommended equipment needed for cleansing that wound with normal saline. Our skill is on page 1224 in Potter and Perry, and as we look at page 1224, we see that we need to make sure that we are providing for comfort, educating the patient as to what we're doing, pre-medicating, gathering all our supplies, washing our hands, and then irrigating that with the correct equipment so that we do not cause tissue damage to that area. This ends PowerPoint number 4.